Hello, I will be continuing to talk about heart failure, and this is going to be part four. I just talked about the treatment, medical management for heart failure, and a few points that I wanted to also mention. Before undertaking physical activity, the patient should be given the following safety guidelines. Trying to increase the activity. And one of the good points is to ensure that you're able to talk during the physical activity. If the patient is unable to do so, decrease the intensity of the activity. Also, wait 2 hours after eating a meal before beginning the activity, and then stop the activity if shortness of breath or pain or dizziness develops. So just stop it, just stop the activity. Also, as a nurse, it would be best to monitor for these signs and symptoms of pulmonary and systemic overload. And if you notice them, report to the doctor. And they should adjust the medicine and probably increase the diuretic. On examination, you would listen to their lungs and you would hear crackles and wheezes, or their absence. If they're absent, then good. Crackles may also sound as gurgling. Gurgling. That's not as fast. Sounds gurgling that may clear with coughing or suctioning. The rate and depth of respirations is important, and we should record it. We'll auscultate the heart, and if we hear that S3 heart sound, then we can suspect the heart failure or worsening of such. A sign that the heart is beginning to fail and an increased blood volume remains in the ventricle with each beat. That's where we'll hear the S3. The nurse makes sure that dependent part of the patient's body are assessed for perfusion and edema, so they are cold and they're edematous, with +3, +4. With significant decrease in stroke volume, there is a decrease in perfusion to the periphery, causing skin to feel cool, appear pale, or cyanotic. So either pale or cyanotic, blue or white, one of those. In extreme cases of heart failure, the patient may develop periorbital edema around the eyes, in which eyelids may swell shut. The liver is assessed for hepatojugular reflex. So that's what I was talking about early signs and symptoms. Hepatojugular reflex, where we press on the area where the liver is, and we for a minute, and then we see the jugular vein distends to 1 centimeter. Then it's a positive sign for hepatojugular reflux. So the patient is asked to breathe normally while manual pressure is applied over the right upper quadrant of the abdomen for 30 to 60 seconds. For 60 seconds, press for sure. If neck vein distension increases for more than 1 centimeter, the test finding is positive for increased venous pressure. The patient is weighed daily in the hospital or at home. So I think I thought about it. If a person, for example, every day they're being weighed, and they just have a good meal, and they go weigh themselves and, oh boy, I just gained 5 pounds. I gotta call my doctor. So that's not the best way. The best way is probably to, every day they wake up, they go to the bathroom, and then they weigh themselves. They pee, they have a bowel movement, they void, they have bowel movement, and then they weigh themselves every day at the same time. Or they have a good meal and then they weigh themselves every day after dinner. And this way they can see it would be more accurate. So the patient is weighed daily in the hospital at the same time of the day with the type of clothing, and on the same scale. If the if there is significant change in weight, 2 to 3 pounds increase in a day or 5 pounds increase in a week, the patient is instructed to notify the physician or adjust the medication, increase diuretic dose. So I just this is my first thing after each meal on a full stomach, or first thing in the morning after bowel movement. So some of the good points I mentioned. And also, so in this diagram, I will talk about medications and the pathways that they affect. So one of the main pathways that most of the meds are directed at is our RAS system. Renin, angiotensinogen, angiotensin 1, angiotensin 2, and yeah, aldosterone system. So when there's a decreased cardiac output, alright, there's my pen. When there's a decreased cardiac output, from the heart, there's decreased perfusion. Decreased perfusion also happens to juxtaglomerular cells that are in the nephrons. They are stimulated and they release renin. And renin cleaves the angiotensinogen that is produced by the heart. That is produced by the liver, and it becomes angiotensin 1. ACE enzyme in the lungs cleaves angiotensin 1 into angiotensin 2, and angiotensin 2 finally has its effect. So it affects the posterior pituitary gland in the brain to release more of the antidiuretic hormone, and it also affects the on the blood vessels. It vasodilates them. Vasoconstricts them. And so they become smaller. And it also affects the adrenal glands. I think the external cortex of the adrenal gland to release more of the aldosterone. So when angiotensin 2 affects the posterior pituitary gland and antidiuretic hormone is released, it works on the kidneys and it increases water reabsorption, which increases the volume, which increases the blood pressure, but also it affects the end-diastolic volume and thus increases the preload. And there is less of this urinary output. With the blood vessels, the more they're constricted, the less diameter there is. Total peripheral resistance is increased, so increased afterload, increased blood pressure is the result. Aldosterone. With aldosterone, there is retention of sodium in water, so it increases blood volume, increases the blood pressure, increases end-diastolic volume, increases the preload. Alright, that's about the effects of all the enzymes in the body and hormones on the exacerbation of heart failure. So that retention of fluid affects the blood. It becomes even harder for the heart to work and it exacerbates the heart failure. So one of the things that we can give is the ACE inhibitors, captopril, enalapril, lisinopril, and they will block the ACE enzyme and thus will not cleave the angiotensin 1 into angiotensin 2, and we can stop all these effects of vasoconstriction, and fluid retention. Sometimes when there's side effects to ACE inhibitors, the effects on the kidneys, we can give this one's angiotensin II receptor blockers. Everything that ends on sartans, valsartan, losartan, condesartan. And to be honest, it doesn't block the angiotensin. Ooh, not that far. It doesn't really block angiotensin, but it blocks the receptors to which angiotensin binds. So it blocks those receptors. And so angiotensin II doesn't have its effect. And those receptors are here on the blood vessels, and those receptors are on the kidneys, and the receptors that are on the adrenal glands. Also, there's a new drug. Called Entresto. What the heck is Entresto? So when the heart is being overloaded with the fluids, it releases this beta natriuretic peptide. It's to release this beta natriuretic peptide. Beta natriuretic peptide, it blocks the angiotensin II. It blocks the angiotensin II, or breaks it down, and angiotensin II doesn't have its effect on the vasoconstriction and fluid retention. So, wouldn't it be nice? So there's an enzyme, unfortunately, that breaks down beta natriuretic peptide. It breaks it down, and the beta natriuretic peptide doesn't have its effect. So wouldn't it be nice to have a drug that would block the effect of this enzyme? Fortunately, there was a drug developed already called sacubitril. Some kind of cube. Sacubitril, sacubitril, that is a neprilysin inhibitor, and that blocks the neprilysin and allows the effect of beta natriuretic peptide. However, the developers probably thought it would be better to have not just one effect, but both effects of valsartans, both the angiotensin II receptor blockers and the beta natriuretic peptide, to block the angiotensin II, and this way improve the potency, increase the potency of their drug. And so they combine sacubitril with angiotensin II receptor blocker, and they call the drug Entresto. Interesting, Entresto. Alright. We also can give aldosterone antagonists, which is the spironolactone and aplernon, and they will block their aldosterone and decrease the volume in the body. So that's this. And let's move on the other drugs. Okay, so when heart is malfunctioning, there's less cardiac output is sensed by jugular receptors in jugular arteries, jugular veins, jugular arteries maybe too. Gotta double check that one. In the jugular arteries, there's receptors, and they stimulate the brainstem to increase the heart rate, to increase the cardiac output, and to increase blood pressure erroneously. Beta blockers stimulate the heart and increase the heart rate and increase contractility. So some of the drugs that we can give are metoprolol and carvedilol and so on. But these drugs are contraindicated with decompensated heart failure. For some reason, they're contraindicated. These drugs are contraindicated with heart failure. With these drugs, beta blockers are contraindicated with decompensated heart failure. To increase the contractility but slow the heart rate, we can give digoxin and dobutamine. Also, so beta blockers will have its effect on the blood vessels of the nephrons, which will lead to vasoconstriction, increased peripheral resistance, increased blood pressure, and increased afterload, and the kidneys will start to decrease the urine production, trying to retain more fluid, sensing that there's a decrease in blood volume, blood supply. So something that we can give is a loop diuretic, furosemide, and thiazide diuretics. They will increase the urine output. Another two drugs which are vasodilators are hydralazine and isosorbide dinitrate. And hydralazine will have its effect on postcapillary arterioles. It will dilate them, and that will lower the total peripheral resistance and decrease the blood pressure and decrease the afterload. And isosorbide dinitrate will affect the venules, the precapillary vessels. It will dilate them, and this will decrease the right-hearted venous return. It will decrease the end-diastolic volume, and it will decrease the preload. So we're dilating them. We're allowing the blood to be present in the blood vessels. So when a person lays on the bed and they want to dangle their feet off the bed and lay like across the bed, then that's what they're doing there. They're trying to let the fluid be in the legs so that there would be less return to the heart, and it will be easier for the heart to work, and also for them to breathe. Okay, with decompensated heart failure, we can use these drugs. We can use Lasix to decrease edema. We can use morphine to decrease pain. And also, morphine has a dilating effect. Effect on the blood vessels. Nitrates will dilate the blood vessels. And remove the chest pain because more oxygen can be delivered. Oxygen is also administered to the patients with decompensated heart failure. Because of the pulmonary edema, they have a hard time of getting oxygen, and when we supply the oxygen, it increases the saturation, makes it better for them to breathe. Position, we elevate their head. We elevate their torso. 40 degrees makes a big difference. Alright, thank you for watching, and this were heart failure series. Please like, subscribe, and comment. Thank you.